Good afternoon, everyone. I have the pleasure of introducing our first speaker to Grand Rounds today, Dr. Joshua TURKELTAUB. And so Dr. TURKELTAUB is an assistant professor in clinical medicine here at the University of Miami Miller School of Medicine in the Division of Gastroenterology and Hepatology. Dr. TURKELTAUB earned his undergraduate degree at University of Arizona, where he was magna cum laude, and then went on to get his MD at Baylor College of Medicine, in which he graduated with honors, was elected to Gold Humanism Honor Society, and AOA. He completed internal medicine residency at University of Michigan, and then went on to complete gastroenterology and hepatology fellowship and advanced fellowship in transplant hepatology at the University of Colorado Anschutz campus in Aurora. Upon completion of his advanced endoscopy or his advanced hepatology fellowship, he went on to serve as an assistant professor at the University of Arizona College of Medicine prior to joining us at the faculty in the fall of 2021. He's published book chapters in bariatric endoscopy, has several first author publications, including on topics ranging from endoscopic techniques, IBD, intestinal protozoa, and helminth infections. He's been very active in the wider academic community, presenting at national conferences as well as several grand rounds. Here at UM, Dr. TURKELTAUB is active in Miami Transplant Institute and works with our GI fellows clinically. Please give a warm welcome to Dr. TURKELTAUB, who will be presenting a talk entitled, "When Transplant is Your Last Best Hope."
Great, thank you so much for having me, and thank you for the kind introduction. I'll be presenting a hepatology vignette today that's titled "When Transplant is Your Last Best Hope." These are my disclosures. So to jump into the case, this is a 35-year-old man who was recently diagnosed with IBS, and he was transferred from an outside hospital with 2 weeks of jaundice and weight gain. He was previously healthy, but he had been experiencing bloating and distension for about 2 months. That led up to a diagnosis of IBS that was made by an outside gastroenterologist. His past medical history is notable for asthma and hemorrhoids. He does have a family history in his maternal grandfather of cirrhosis that was presumed to be due to alcohol use. He doesn't take any medications, no herbal medications or supplements, no prior tobacco use or drug use. He does report a history of alcohol use, maybe 4 drinks a week at most, and no recent travel or sick contacts. On review of systems, he describes anorexia, early satiety, weight gain, and bright red blood per rectum. Going over his physical exam, his vitals are normal, but he is obese with a BMI of 37. He has conjunctival icterus, he has mild distension in the abdomen, and then in his skin, he's jaundiced and has spider angiomata on the anterior chest wall. At this point, he's alluric organ types 3, and there's no asterixis. So starting off with our initial workup on day 1 of his presentation to our hospital, notable findings that are either normal or abnormal at this time: his hemoglobin is 13.2, sodium is 132, his creatinine is 0.84, and he has a glucose of 71. His LFTs are notable for an AST of 177, an ALT of 81, alkaline phosphatase is 97, total bilirubin is 13.6, and INR is 3.1. His viral hepatitis panel is just notable for being vaccinated against hepatitis A and hepatitis B, HIV negative. He does have a mildly elevated AFP and a high iron saturation, and his drug tox screen is negative. We then get some imaging with a cross-sectional CT, which shows a cirrhotic appearing liver with splenomegaly and small volume ascites. A chest x-ray shows a small right pleural effusion. And so kind of based on this presentation, we think that he has decompensated cirrhosis with a MELD of 31, and a transplant evaluation is initiated, and his workup for the etiology of what's going on is continued. Now, fast forward a number of days, so now we're going to day 7 of his hospitalization. His workup has continued during this time, but now his MELD is up to 40. And so notable changes in his labs now: his hemoglobin has dropped from 13.2 to 8.9. His creatinine is now up to about 5 from previously normal at 0.84. His sodium is 120. Looking at his LFTs, His AST is 144, ALT 33. His alkaline phosphatase has notably dropped from 97 to 51, and his total bilirubin has increased significantly up to 34 with a direct component of 21, and his INR is 3.1. Other labs that have returned are ferritin, that's markedly elevated of about 2,500 with an iron saturation of 100%. His ceruloplasmin is about 19, his serum copper is 181, and his 24-hour urine copper is 142. Looking at the rest of his testing here below that, he has negative ANA and ASMA, anti-smooth muscle antibody, with maybe a borderline positive IgG. His PEth, which looks for metabolites of alcohol use, is negative. Other tests that are notable is that he has a low haptoglobin and an elevated LDH with a negative Coombs test, and his blood smear does show a few schistocytes. Another important change on day 7 is that now he is allurium-oriented ×2, and he has developed asterixis. Based on some of the findings on the prior page, ophthalmology is consulted to look at his eyes, and he does not have any KF rings. Hematology is also consulted due to the concern for hemolytic anemia, and they do agree that he has a Coombs negative hemolytic anemia, and they recommend initiation of plasma exchange for removal of copper. Nephrology is also consulted for his acute renal failure, and they feel it's likely multifactorial due to contrast, heme pigment, bile cast, copper, in the setting of portal hypertensive physiology, and they also recommend plasma exchange for emergent copper removal, in addition to initiation of CVVHD. So how do we put this all together? This patient seems to have acute liver failure due to Wilson disease, and I'll go into this a little bit further. The acute liver failure diagnosis is made on the combination of having encephalopathy and coagulopathy. The Wilson disease diagnosis here is made on the combination of having an elevated 24-hour urine copper, a low ceruloplasmin, as well as the presence of a Coombs negative hemolytic anemia. And this is further supported by a low alkaline phosphatase. He's ultimately listed status 1A, which is the highest category of listing that we can do. And this is despite having a chronic underlying liver injury or cirrhosis. And this is because acute liver failure in the setting of Wilson disease is largely considered fatal without transplant. And so he's ended up getting transplanted within 72 hours. So the objectives for my talk today are to recognize the different presentations and manifestations of Wilson disease, to identify the different tests that are utilized in making the diagnosis, and also being familiar with the different treatment options for Wilson disease. So Wilson disease was first described in 1912 by Kinnear Wilson. At that point, it was called hepatolenticular degeneration. This is an autosomal recessive disease of impaired copper excretion, and this is due to a mutation or defect in the ATP7B gene. There are more than 500 described mutations to this gene, which is the copper transport protein. And when this has a mutation, this affects copper not being incorporated into ceruloplasmin, and affects excretion of copper into the bile ducts. This results in systemic accumulation of copper, and ultimately this is a disease that is fatal without treatment. So lifelong treatment is required, and that's a very important point. This is found worldwide with an estimated prevalence of about 1 in 30,000. Typically, people with Wilson disease are on the younger side compared to the other patients that we see with cirrhosis, more so in the ages of 5 to 35, but it has been described in patients as old as 70 or 72. With our patient's presentation with acute liver failure, the median age of presentation is about 25, and this is more commonly seen in women. So in terms of the mechanism of Wilson disease, the ATP7B protein, again, is the copper transporter protein. And so with mutations, there is reduced incorporation of copper into with apoceruloplasmin. So 6 copper ions added to apoceruloplasmin make your ceruloplasmin or holoceruloplasmin protein, and that's ultimately what's excreted into the blood. And so that's why there is reduced ceruloplasmin in the blood in the setting of chronic Wilson disease. ATP7B is also a protein that's involved with transporting excess copper to the biliary canaliculi to help excrete excess copper. And so when that's impaired, there's also decreased excretion of copper. This ultimately results in toxic buildup of copper in the hepatocytes, leading to mitochondrial and oxidative damage, and the excess copper is essentially spilled into the blood. So copper has a number of effects on the body, and I'll go into this a little bit more detail. In the liver, increased copper may cause mitochondrial damage, resulting in steatosis of the liver. Ultimately, apoptosis of hepatocytes can occur, fibrosis, cirrhosis. It can affect the red blood cells, can cause what's thought to be red blood cell membrane fragility, resulting in hemolytic anemia. It can affect the brain through deposition of copper in the basal ganglia. It can affect the kidneys, the bones. It has a number of effects throughout the body. And this is a limited diagram here. There's many more effects that are just that are listed that are just here. But in terms of liver disease, the presentation of Wilson disease can range from asymptomatic abnormal liver enzymes to acute liver failure, cirrhosis. It's also can affect people from a neurological or psychiatric perspective. The most common psychiatric manifestation is depression, which can be seen in about 20 to 30% of patients. From a neurological perspective, the most common presentation is dysarthria, but movement disorders can be seen, ataxia, dystonia, chorea. So there's a number of presentations with Wilson disease. As pertinent to our patient who presented with acute liver failure, some of the key points here is that there's oftentimes a modest elevation of AST and ALT in this ratio of about 2.2 or greater than 2.2. There also tends to be a normal or subnormal alkaline phosphatase. With the alkaline phosphatase, the total bilirubin ratio of less than 4. And so what I've highlighted here at the bottom right here is that the AST to ALT ratio, as you can see here, is greater than 2.2. And the alkaline phosphatase to total bilirubin ratio, as you see here, is definitely less than 4. And this is a very common finding that you see in patients that present with acute liver failure in the setting of Wilson disease. It's markedly low, the alkaline phosphatase. Again, in acute liver failure, we also see Coombs negative hemolytic anemia. We oftentimes see a very high bilirubin, rapid progression to renal failure, coagulopathy. Many patients already have advanced fibrosis or cirrhosis at this time. We talked about ceruloplasmin briefly, how it is a test that can be used to diagnose Wilson disease, and we'll go into this a little bit further in just a moment. But in this situation with acute liver failure, this test is unreliable as it is an acute phase reactant. Once someone develops acute liver failure with Wilson disease, transplant is largely considered to be the only effective treatment. Talking a little bit more about the Coombs negative hemolytic anemia, the mechanism is not totally understood, but it's felt that increased copper ions in circulation causes oxidative injury to the red blood cells, resulting in this Coombs negative hemolysis. This is most commonly seen in the setting of acute liver failure from Wilson disease, but can also be seen episodically in chronic Wilson disease as well. Once this occurs, typically recommendations may range from hemofiltration, plasmapheresis, or albumin dialysis, and ultimately transplant would be the ultimate fix for this. Copper chelators are not helpful for the treatment of this Coombs negative hemolytic anemia. So how to make the diagnosis of Wilson disease? So it's a combination of clinical findings, biochemical testing, liver biopsy, and genetic testing. And it's important to know that none of this is perfect. There are limitations actually to each test, which makes it sometimes very difficult to make this diagnosis. So talking about the first part of this is Kaiser-Fleisch rings or KF rings. We probably all recall this from medical school. So this is granular deposit of copper in Descemet membrane in the cornea. This is seen about 50% of patients who present with a hepatic manifestation of liver disease, but not all patients have this presentation. Those that have neuro or psychiatric symptoms have KF rings more frequently, up to 95% of patients. This can also be seen in other conditions such as chronic cholestatic liver diseases like PBC, so it's not exclusively seen in Wilson disease, and this will require a ophthalmology consult, and typically it's recommended a slit lamp exam is performed, not necessarily just a bedside exam to look at the eyes. Ceruloplasmin is that common test that we oftentimes remember as well for screening for Wilson disease. It's important to know that this is also not a perfect test. Less than 20 may be suggestive of the diagnosis, and lower values are even more suggestive. But again, this is an acute phase reactant. And so normal values cannot necessarily exclude Wilson disease, and it can be lower normal and even up to 40% of patients. Some things that can make the ceruloplasmin elevated in patients who don't have Wilson disease include acute liver failure from other causes, pregnancy, as this can be estrogen mediated, the transcription of ceruloplasmin, as well as acute hepatitis. It can also be low in patients without Wilson disease who just have cirrhosis because of synthetic dysfunction or renal failure due to losing protein. Serum copper is oftentimes checked to help make the diagnosis of Wilson disease. The total serum copper is oftentimes decreased in chronic liver disease from Wilson disease due to the low circulating ceruloplasmin. However, in acute liver failure, because of significant hepatocyte necrosis, there's a lot of release of copper into the blood. And so oftentimes the copper is actually normal or even increased. So this is not a perfect test for making the diagnosis of Wilson disease. There is a component of this that can be calculated called the free copper or non-ceruloplasmin bound copper, which can be used for monitoring patients on chelation therapy, but that's kind of outside the scope of this talk. Checking the 24-hour urine copper is an important part of making a diagnosis as well, and this reflects the increased circulating free copper. Again, this is used for diagnosing and monitoring patients who are on chelation therapy, and it is a 24-hour urine copper test that must be performed using a metal-free container so as not to interfere with the calculation of copper. It cannot be a spot collection because spot collections are not as accurate. There's too much variability. A positive test would be considered greater than 100 micrograms of copper. However, there is increased sensitivity if you lower that value, so greater than 40 micrograms may require further investigation. Just like with the other tests, there are limitations with this, such as renal failure. You may have decreased urine volume, so you may not be able to actually collect your urine copper. And this may also be increased with hepatocellular necrosis and chronic cholestatic liver diseases. So we talked about liver biopsy may be indicated to help further clarify if someone has Wilson disease. But there's an important caveat this. We can look at histology, but we can also measure the hepatic copper concentration. And for this situation, the hepatic copper concentration is a little bit more important. Again, we typically can consider this if the diagnosis remains unclear after initial testing, and it's important to order this correctly. And what I mean by that is typically, again, we ask for a biopsy. They send off one core to look at it under the microscope, to look at the histology. But in this situation, it's oftentimes recommended to get two cores, one for routine histology and a second one to be placed in a copper-free or metal-free jar without formalin, so placed dry, and that way it does not interfere with the calculation of copper. And so it's important to specify that when you order the biopsy and letting the pathologist know that you're requesting a copper quantification. An abnormal copper quant is considered over 250 micrograms, and normal is less than 50 micrograms. There are situations where there may be intermediate values, perhaps it's a heterozygote for Wilson disease, and there's also variable distribution of copper in the liver in setting of Wilson disease. So there can be sampling error. You can actually have a falsely normal hepatic copper concentration. And just like with the other tests, you can have this elevated in other liver diseases as well. Briefly talking about the histology, this is not as important in this situation as it is with other etiologies of liver disease because there's so much variability, not a classic finding that would help make the diagnosis of Wilson disease on histology. You might see glycogenated nuclei, you might see hepatic steatosis, cirrhosis. It's very nonspecific. The copper stain that's used is rhodamine, and this can be helped to help stain the copper, but it's not typically the test to really confirm that you have a diagnosis of Wilson disease. And not having positive copper staining does not mean that you do not have Wilson disease. Lastly, looking at genotyping or checking for genetic mutations. Again, there are many, many mutations, more than 500 mutations of the ATP7B gene, and many patients may be compound heterozygotes. It sequences the entire gene, the ATP7B gene, and this is usually helpful for unclear cases where all of your prior testing is inconclusive or for family screening purposes. This is actually our patient's ATP7B gene testing. You can see that he was actually homozygote. So how do you put this all together? There's a number of algorithms that are out there to help you kind of guide each step in terms of what test you should check next. But this is a scoring system called the Leipzig scoring system, which basically assigns a point value to each test and each abnormality associated with the test. And depending on your overall point total can help make you determine if you have made a diagnosis of Wilson disease or if it's just likely if more investigation is required. And so you can see here, depending on the degree of ceruloplasmin, or depending on the elevation of urine copper, elevation of the copper concentration in the liver, presence of Kaiser-Fleisch rings, you ultimately can help make this diagnosis. And so for our patient who had a low ceruloplasmin of 19, he gets a point there. He had an elevated 24-hour urine copper at about 140, so he gets 2 points there, so that's 3 points. And then he also had a Coombs negative hemolytic anemia, so he had 4 points, which would help make the diagnosis of Wilson disease. The mutation analysis actually came back after transplant, and so he would have gotten the 4 points there, and that's not something that comes back right away and did not help ultimately make his diagnosis of Wilson disease. So we're briefly going to talk about the treatment of Wilson disease. So chelation therapy is the first line for symptomatic or active Wilson disease. And this basically, the idea behind this is to increase copper excretion through the urine, and this helps normalize the free copper in the body. The initial medication used to treat this with is called D-penicillamine. This has the most experience, it has been around the longest, but there are many side effects to this medication, and many patients therefore don't tolerate it. So kind of the second line medication, if insurance is able to approve it, is called trientine, less side effects, better tolerated, but maybe more difficult to get. Another medication that can be used to help treat Wilson disease is zinc. Tends to be used more so in asymptomatic patients or patients who have already had improvement in their free copper after they've already been put on chelation therapy. Zinc basically decreases copper absorption, has less side effects, and less expensive than the chelators. Regardless of which route you go, diet is also a crucial component of treating Wilson disease. It's important that patients follow a low copper diet. They have to avoid things like shellfish, nuts, chocolate, mushrooms, organ meats, soy-based products. Some of these alternative milks may also have increased copper. It's important that patients check what kind of water they have. Are they well-based water? What kind of pipes do they have? A lot of kind of things go into make sure that patients follow a low copper diet. Transplant for Wilson disease is curative. But regardless of whether the patient gets a transplant, or rather if they don't get a transplant, patients need to remain on pharmacotherapy for life, including through pregnancy, because stopping pharmacotherapy can result in flares of the disease and can result in the liver failing. Very briefly going over family screening. So if a patient is diagnosed with Wilson disease, the recommendation is that first-degree relatives are screened due to the increased risk of them, of course, having the disease as well. If the proband's genotype is known, it's recommended that you start off by getting the genetic testing. If the proband's genotype is not known, you can start off by getting the clinical and biochemical assessments. And if there is concern for liver disease in a family member, getting the clinical and biochemical assessments in addition to the ATP7B gene in the setting of knowing the proband genotype is also recommended. If treatment is started before symptoms begin, then disease progression can be prevented. So key take-home points from today. Wilson disease is an autosomal recessive disorder of copper metabolism. The presentation can be variable, again, ranging from asymptomatic to fulminant liver failure, like with our patient. The diagnosis consists of a combination of clinical exam and diagnostic studies, but each test has a number of limitations. So you always have to think about Wilson disease in the back of your head, even if the test may come back as normal. Treatment is lifelong without transplant. So it's very important that patients take their medication for life if they're not transplanted. That's the end of my talk. Any questions?
Dr. TURKELTAUB, that was an outstanding presentation, very crisp and clear. And you know, every time I thought I was going to have a question, your next slide answered it. So that was good, except, and maybe others in the audience will have questions as well. Is there any consideration given to the donor's genetic status in transplanting a patient who's known to have, to be homozygous for a particular mutation? One would imagine that potentially, if it was a young donor who hadn't yet manifested signs of Wilson's disease, that it might be not a good idea to do that in any recipient, but specifically in this recipient known to have Wilson's. Is there any comment you have on that?
If I'm understanding your question correctly, are you asking if patients who are listed for transplant and are receiving an organ offer, if they are screening those patients for Wilson disease, and what would happen if they received that organ? Is that what the question is?
What more in terms of if the donor organ were affected?
If the donor organ affected, I'm not aware of circumstances of where the donor organ would be affected. If once Wilson disease, once they're transplanted, Wilson disease is out, the copper in the body should normalize. And there really is otherwise not enough time to do genetic testing for the donor organs to make sure that they don't have Wilson disease. There are actually reports of patients receiving a heterozygote organ with Wilson disease who do not manifest Wilson disease later on in life, and those patients have done well.
Thank you, Josh, and thank you, David, also for your comments in the chat. Any other questions from the group?
Roy,
Dr. Gardner.
a quick question. Excellent presentation. Given the potential side effects of lifelong treatment, How well is it tolerated, and how effective is it in patients where you wish to avoid the complications you've just talked to us about?
Yeah, so there are a number of not great side effects with the combination of therapies. So for example, with the D-penicillamine, patients can develop renal failure, thrombocytopenias, pancytopenias, drug reactions. There's a number of side effects where patients really cannot tolerate the medication. Trientine is a much better tolerated medication. Patients tend to do much better on that medication long term. And so ultimately, most patients that I see, if their insurance approves it, tend to do very well long term on Trientine, as long as they remain on that medication, follow a low copper diet, and never really manifest it with decompensated liver disease. Many patients will not then further progress again as long as they're following the low copper diet and taking that medication. Patients who are on zinc have minimal side effects. There's really no ill long-term side effects that make it difficult for those patients to take that medication long-term, and many of them don't have any issues as well. Yeah, I think the most important point is that patients who present with Wilson disease, if it's already fairly decompensated, it's probably too late to have them start on these medications to help preserve what they have. But if it's started early enough, transplant can be avoided. Their liver can be preserved as long as they're compliant with therapy, and many of them can avoid long-term effects.
Thank you.
Thank you. Thank you again, Dr. Turkeltaub. Dr. Ubu, I turn the microphone over to you.
All right, and so I have the privilege of introducing our second speaker, Dr. Susie VEHAR. I hope I said the last name correctly. I apologize. And so Dr. VEHAR is assistant professor in clinical medicine here at the University of Miami Miller School of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine. She completed her undergraduate degree at University of Colorado, Denver, continuing our Colorado theme, where she graduated magna cum laude. She went on to earn her medical degree at University of Wisconsin in Madison. From there, she completed internal medicine residency at Cleveland Clinic, was selected as the chief resident at Cleveland Clinic, and then went on to complete pulmonary and critical care medicine fellowship. From there, she came to join us. And in her career, she has several first author peer-reviewed publications, many of which focus on post-acute sequelae of COVID-19. She's been an advocate in written media, fighting against tobacco products and raising awareness for tobacco-related death. She's been involved in curriculum development for fellows, has hosted several workshops nationally at the American Thoracic Society and at Society of General Internal Medicine, as well as locally. And at each stage in her career, she has won multiple awards. Please, can we extend a warm welcome to Dr. Susan VEHAR, who will be presenting a case vignette to us about diffuse parenchymal lung disease.
Thank you so much. That was an incredibly kind introduction. I'm really excited to be here and have joined the University of Miami recently. As we're getting started here, I'd like to try to use the Poll Everywhere audience response system. In order to respond to the poll, if you text my full name, Susan VEHAR 761 to the number 22333, that's the number that you're texting it to is 22333, and then in the text message itself, Susan VEHAR 761, and we'll see how that goes. So thank you. I'll be presenting a case vignette about diffuse parenchymal lung disease. I do not have any disclosures relevant to today. One thing I would like to point out is that I will be using the term interstitial lung disease and diffuse parenchymal lung disease interchangeably throughout the talk. As I'll mention on a couple different occasions, we have been updating our nomenclature for these diseases, and one thing to point out right away. My objectives for today are to review an approach to the nomenclature and diagnosis, to talk a little bit about initial evaluation and referral to our ILD GTLD clinics here, and to review some of the key updates and guidelines, as well as treatments available for progressive pulmonary fibrosis. With that, I'll jump into my case for today. This 48-year-old male, he's a current smoker. He was actually referred to the rheumatologist by his primary care physician for joint pain that's been going on for the past 6 months. Examination shows synovitis of multiple joints with associated tenderness. Lab results, he has a positive rheumatoid factor, positive CCP, and elevated inflammatory markers. With the rheumatology appointment, he is diagnosed with rheumatoid arthritis and started on prednisone and methotrexate. A few weeks later, he presents to the emergency department with chest discomfort. He has a chest x-ray that is notable for increased interstitial markings. Your typical evaluation for a chest pain, rule out troponin, EKG, infectious workup labs are essentially reassuring, and he's discharged home with close follow-up with primary care. So don't worry, as I told you, I'm a pulmonologist. The diagnosis here isn't a secret, but in thinking about how rheumatoid arthritis relates to my specialty, I'd like to ask the audience as a poll question here. Again, you can text Susan VEHAR 761 to the number 22333. So what is the prevalence of diffuse parenchymal lung disease in patients with rheumatoid arthritis? Less than 1%, 1 to 5%, 5 to 10%, or more than 10%? Great, glad to see that the polling system is working here. It looks like C is the most common answer. And I'm going to try and convince you that I think that D is actually the best response. In looking at the data, most studies estimate RA-ILD more than 10%. It's difficult to say who they include in all these studies, certainly some caveats, but I would argue at least it's worth knowing that this is a relatively common diagnosis in patients that have RA. Associated with risk factors, including male sex, smoke exposure, inflammatory markers, positivity of the anti-CCP, methotrexate, or DMARD use, as well as older age at onset, many of which are true for the patient that I've presented to you today. Rheumatoid arthritis-associated ILD is also associated with higher morbidity and mortality, with the 5-year mortality estimated around 36%. Again, I may be jumping to where you may see this at the end of a talk. However, it's important to, again, get your attention that this is relatively common and something we can look for, and it has some serious outcomes to be considered. And with that, as I've mentioned, I'd like to talk more broadly about diffuse parenchymal lung disease and the basis of this case. In order to do that, I think it's worth just taking a step back for a moment to talk about what is diffuse parenchymal lung disease. I think we all can acknowledge the alphabet soup and the many abbreviations that come with it. And it's actually fun to look at a little bit of the history of why this came to be. I really like this picture from the Clinics in Chest Medicine published in 2021. And looking at the timeline, you're starting in the early 1800s, finishing around 2000. The blue boxes on the top there are the clinical descriptions of how we've been describing interstitial lung disease, such as cirrhosis of the lung. I think that's a very detailed and picture of how this has been described. You see that the orange and the green boxes are also looking about other exposures or clinical findings. But then what really grabs my attention in this picture is the technology that comes with it. If you look in the gray box, 1816 development of the stethoscope, then the X-ray, flexible bronchoscopy, and it's not even until 1971 that we have the CT scan, which is arguably outside of the field of radiology, where I spend a lot of my time looking at scans, assessing patterns, and putting it all together for these patients. So I hope it helps to at least give us the rationale of why there is an alphabet soup as we continue to learn so much and advance our technologies today. And what I would say is that diffuse parenchymal lung disease is the umbrella term encompassing more than 200 different diagnoses and with hundreds of years of history behind it. And then in trying to break that down, you can look at many different algorithms of how to break this down, to categorize, to treat. I like to simplify it into 4 basic ideas. Starting here with the 2 simple ideas, is your etiology known or is it unknown? In the etiology known category, you're looking at the connective tissue diseases, thinking about rheumatoid arthritis, polymyositis, scleroderma. In the inorganic exposures, that's your asbestos, silica, hard metal, coal. Organic exposures, thinking about bird, hay, mold, mycobacterial exposures. Smoking-related interstitial fibrosis, pulmonary Langerhans cell histiocytosis. Drugs, that includes medication, includes illicit drug use or other exposures, things like nitrofurantoin, amiodarone, methotrexate, chemotherapy. We have an entire clinic dedicated to pneumonitis that has been associated with chemotherapeutics. Also recalling back to fairly recently, thinking about vape-induced lung injury and e-cigarette use. And then on the other side, being your etiology unknown, that's your idiopathic. I put in a QR code that leads to the ATS guideline that we're going to talk about a little bit later from 2022. However, again, there are many ways to break this down, but the etiology known category helps to guide your history and some of the initial serologies that you might think at more of an initial visit. The other part, when I said I had 4 categories, so known, unknown, and then I look into, is it inflammation or fibrosis? Most of us think of this as being on a spectrum of disease. Some diseases falling more on the inflammation or only on the inflammation side of the spectrum, and then the fibrosis side being on the opposite. We recognize, especially now, that many of the diseases lay somewhere in between, and often one of the main concerns is that inflammation untreated may lead into fibrotic type of lung disease or a fibrosis predominant pattern. Pausing for some key takeaways of what we've talked so far, that DPLD is the umbrella term, known or unknown, inflammatory or fibrotic, and that rheumatoid arthritis is one of the notoriously common ones that can be associated with interstitial lung diseases. Coming back to our case, this patient denies really any respiratory symptoms. It's the chest x-ray markings and some chest pain that may or may not have been related to that brought him to attention. He has no other previous imaging, right? When people ask for an EKG, you often ask for the previous. I would encourage you to do the same with the chest x-ray or with the CT scan. The patient is currently being seen by the primary care physician who appropriately counsels him on smoking cessation and then refers him to our pulmonary ILD clinic for further evaluation. Pause here for another audience question, the login information there at the top. In addition to the pulmonary referral, what is the next best step? Is it a CT with contrast and pulmonary function testing, a non-contrast CT chest along with PFTs, high resolution CT chest and PFTs, or only PFTs along with the referral? Great. And I agree that C is the best answer. Let's dive in a little bit of why. Thinking about the high resolution CT chest, this is going to give you those thin cuts, the 1 to 1.5 millimeter cuts with high spatial frequency. In our protocol, you're going to get both inspiratory and expiratory images, as well as prone imaging. This is a nice picture showing in the treatment of ARDS why proning would benefit a patient, but the concept is the same, in which you are eliminating the atelectasis and gravitational changes to see if those interstitial changes persist in order to help you make a diagnosis. As far as the thickness of the cuts, imagining that you have thicker cuts and less information to feed the computer, it's one way that the computer would have to imagine what's in between those two things, just in the sense where you get motion artifacts and the computer has to do more imagination. It results in more ground glass opacifications and potentially an overcall. So ideally, thinking about the CT scan, you want high resolution and with the prone cuts and a full inspiration to help give you the best chance to determine the pattern that you see and as well as follow the progression of disease. Here's one picture again showing what happens. Supine in the left panel, the prone image in the right, where you can see with eliminating gravity, those changes resolve, and that makes us less likely to be interstitial lung disease. Here's the initial CT scan from our patient. This is a prone image. It's actually just been rotated on your screen. You can tell that by the positioning of the table and the blankets. And what you saw here was the changes in the bottom part of the scan. You go to the still images here in both the coronal and axial images. And you see those ground glass reticular hazy changes, mostly bilateral in the lower lung zones. You may be able to imagine some subpleural sparing here, which would be suggestive of an NSIP or non-specific interstitial pneumonia pattern. Unfortunately, along with the alphabet soup, and while we create time for us to adjust some of our language here, there are just some flavors that I think it's important to know. 3 of them that I would promote for today, especially for this audience, the general medicine background: usual interstitial pneumonia, UIP, non-specific interstitial pneumonia, or NSIP. And one of the newer terms, which I think is important for how we've changed our management and prognosis of these patients, is progressive pulmonary fibrosis, or PPF. Let's start with NSIP. It's temporal and spatially homogeneity. There's ground glass opacity. They're usually symmetric, and they are diffuse or basal predominant distribution. The immediate subpleural sparing is one of the highlighted features. It does not always have to be possible. And it's commonly associated with our inflammatory type of diseases. In this case, I used our patient as the example here. Contrasting that to usual interstitial pneumonia, this is subpleural and basal predominant distribution, but is more heterogeneous. You'll see honeycombing with or without peripheral traction bronchiectasis, which is signs of fibrosis. It can be idiopathic or related to connective tissue diseases. Both of these terms, NSIP and UIP, correlate to an image or a histopathologic diagnosis. It requires clinical correlation. In and of themselves, as a simplified statement, they are not a diagnosis unless they truly become to be idiopathic. But in general, you should think of it as a pattern that you see on image or pathology results. NSIP is often associated with underlying connective tissue disease, as well as inflammatory type of processes. UIP is associated with fibrotic disease and IPF, but it is important again to realize that UIP does not always equal IPF and can be a pattern in many of our other diseases, and rheumatoid arthritis is certainly one of those diseases. Quick pause for some more takeaway points, that the non-contrast high-resolution CT scan with prone imaging is important. Pulmonary function testing. So perhaps unfair that I'm giving you new information and a take-home point, but we're going to come back to why this is part of the prognosis and monitoring. So when you get pulmonary function testing, the ask would be to include your FVC, your forced vital capacity, as well as your DLCO, because that's going to be an important thing for us to trend when we look at management and severity of disease. Coming back to that later. UIP is not always IPF, and the clinical correlation, it cannot be underestimated here. Moving back to our patient, the pulmonary function testing shows an FVC of 4.5, which is 83% of predicted. The DLCO, which is corrected for hemoglobin, is 63% predicted. We've looked at the CT scan with our NSIP pattern. He's seen in the pulmonary clinic, diagnosed with a mild and probably early diffuse parenchymal lung disease in the setting of rheumatoid arthritis, thought to be less likely related to the methotrexate, and the patient was continued on this, as well as the prednisone taper that had already been prescribed by the rheumatologist. Because of his lack of symptoms, early changes, it was recommended that he had serial pulmonary function testing approximately every 6 months or so, with pulmonary follow-up and certainly closer follow-up if anything were to change in the meantime. He continued to follow up with rheumatology with a persistent joint pain. Sounds like tried a couple of other treatments in the meantime, and probably for a multitude of reasons, unfortunately, was a loss of follow-up to pulmonary medicine for 9 years thereafter. He did then develop slowly progressive dyspnea on exertion and was referred back to the pulmonary clinic, and a follow-up PFTs and high-resolution CT scan are appropriately ordered. So here's the follow-up scan. You'll see the initial changes that were still there, but there's been a significant change with more fibrotic features, especially in the lower part of the scan. See more evidence of fibrosis, reticular changes, as well as cystic or honeycomb type changes. Here again with the still images so that you can really see how drastic of a change this is, even though his symptoms have been slow. This graphic represents his pulmonary function testing. Decreased, the blue line is the FVC, the orange is the DLCO, looking at the percent predicted. Of course, there's several missing data points, and not surprising that there's a decline here. So back to you in the audience, what is our next best step? A, discuss at multidisciplinary meeting. B, stop his immunosuppression and start antifibrotics. C, refer the patient to palliative care. This is too advanced a disease for treatment, or D, to continue the current treatment, and that this is essentially the natural history. Great, the most common answer here is A, and looks like we're swaying the vote, which is perfect. I would say that A is the best answer to discuss at multidisciplinary meeting. This is actually something that's been accepted as a gold standard in looking at DPLD diagnosis on a worldwide stage. It's been consistently shown to change diagnosis in up to half of the patients, and goes with a collaborative diagnosis that is more concordant with the outcomes, which is perhaps one of the most important things. Interesting fact that some countries mandate a multidisciplinary meeting in order to make a diagnosis, Australia being one of them. In order to make a diagnosis of IPF, this is part of their mandate. And here I would love to take the shameless opportunity to introduce you to the University of Miami DPLD team, which I have recently joined, and it's been such a pleasure working with all of these individuals. And this is a team that meets on a weekly basis. We bring cases every Thursday. We have representation from pulmonary medicine, rheumatology, interventional pulmonary, who can help us looking at the scans, what kind of biopsy we may be pursuing, and also offers cryobiopsy at our institution, thoracic radiology, pathology, transplant, as well as the surgical team are also involved in these meetings, and it's a fast way for us to refer when we need to. We have a coordinator, pulmonary hypertension input, and it's really been an amazing experience to join so far, and I hope that we'll be seeing your cases. Back to our case. This gentleman's case was discussed at our MDD a couple of weeks ago. We favor that he had a fibrotic NSIP in the setting of his rheumatoid arthritis-related ILD. We felt it was less likely related to his exposures or medications, because certainly some of the medications he's on could be implicated. At our discussion, we had talked about either continuing his current regimen or actually even augmenting, but pending some additional information. Our team discussed whether or not a biopsy would change our diagnosis or recommendations, and overall felt to be not necessary at this time. And we recommended treatment with antifibrotics, as well as a referral to our lung transplant team for at least an initial evaluation. And with that comes some of the newer data based on a couple of different trials, and then our most recent ATS meeting in 2022, as far as the criteria for progressive pulmonary fibrosis. This is a new definition that has come about, and it comes in a patient who has ILD that is not idiopathic pulmonary fibrosis with at least two of the following: worsening respiratory symptoms, physiologic evidence of disease progression, that being defined by an absolute decline in FVC percent predicted by 5%, and an absolute decline in your corrected VLCO by greater than or equal to 10%. Again, that's important of when we're obtaining the pulmonary function testing at initial and for serial monitoring, part of the thing that we're looking for to help us understand the physiology and the progression of these diseases. The third criteria here is the radiologic evidence of disease progression. Again, a QR code. Again, this is really fairly new information and guidelines from 2022. And one of the main trials I think is worth mentioning here was the INBUILD trial from 2019. Your endpoint here is going to be FVC decline and the percent predicted. This has been shown to correlate with mortality and is one of the better available tests and is our usual outpoint. Again, to note that we're talking about restrictive lung diseases, but following the FVC is one of the most important indicators. And in this study, they looked at patients that had fibrosing type of lung diseases, often related to autoimmune or hypersensitivity pneumonitis. It was double-blind placebo-controlled using nintedanib, which is one of the antifibrotics, versus a placebo, and they monitored the decline in FVC over 52 weeks. You can see the dark blue line on the top is those patients that are treated, which did better as far as less decline compared to the lighter blue line in the placebo group. Another important thing to highlight here is it was a slowing of progression. It did not make these patients better. There were also no differences in the quality of life or mortality in these patients. There was a trend that was not statistically significant for time to exacerbation. That being said, we have a lot of work to do, but it's a new offered treatment available and has changed how we're managing many of these patients. Coming back to this figure in an attempt to put it all together, when you're thinking of ILD and the inflammation and fibrosis type of spectrum, if it's inflammation, you're going to be thinking more about immunosuppression. Somewhere between, you're looking at combination therapy of immunosuppression and antifibrotic, or if you lean towards a mostly fibrotic phenotype, looking at antifibrotics, and not just for IPF, but for other lung diseases as well. In thinking about where you may see these patients, it's important to recognize some of the adverse effects of these commonly used treatments. This is a little bit broad because I'm not talking about some of the specific immunosuppressions, but in a broad sense, immunosuppression will come with an increased risk of infection, liver injury, bone marrow suppression, and GI intolerance. This requires us to monitor labs as well as think about what prophylactic medications we may need to be adding. For the antifibrotics, the most common side effects of the two that we have, nintedanib or pirfenidone, will either be diarrhea, GI intolerance, also can create liver injury as well as weight loss. Another important public service announcement here is the use of prednisone. I think many times we think about my subspecialty in ILD as using a lot of steroids. actually, most of our goal is to get patients off steroids as quickly as possible. It comes with some of the harshest side effects over the long term. So our goal is to categorize the patient, make a diagnosis, and think about how we can get them on a steroid-sparing agent as soon as we can. Key takeaway points again here is that progressive pulmonary fibrosis is a relatively new classification that is added to a CPLD that can be from many different causes. Treatment is going to depend on many features, and it may involve immunosuppression, antifibrotics, or a combination of the two, and that multidisciplinary meetings are considered a gold standard and something that we offer here at UM and are very proud to do so. One more question here. What is the prognosis for our patient with RA-ILD who now has evidence of progressive pulmonary fibrosis? Is it A, less than 3 years median survival, B, 3 to 5 years, or C, unable to determine? Great. I think the best answer here is C, unable to determine. And let me talk about why. I know that you've probably been familiar with this life expectancy of 3 to 5 years. And I tell patients straight out, especially in our first meeting, and I would encourage you to do so when you're putting the words UIP, pulmonary fibrosis, anything near it to your patient, that when they Google this, Google is going to tell them that their life expectancy is 3 to 5 years. And the problem here is that it's oversimplified. It's based on older data, and it doesn't take into account why they have the pulmonary fibrosis. So I like to tell patients when you Google, right? You can try and tell them not to Google. That's usually they end up doing so. So I try and reassure them that this data may or may not apply to them. You know, they may have an advanced lung disease, but it's an important conversation to have in thinking of what their prognosis looks like, and that's what's going to be out there. This is an example for this patient with RA-ILD, looking at survival curve. They are looking at here by their high resolution CT scan patterns. UIP, which is associated with fibrosis, tends to do the worst in all disease types versus other patterns. But even so, in looking at 6, 7, 8 years out, the availability of our CT scan, additional diagnostics, and treatments are not always taken into account in many of these studies and need to be updated. Prognosis is going to depend on many things: their age, their comorbidities, what kind of treatment is available to them. And hopefully these are things that we'll be able to release in the future so that patients aren't having to Google those more dismal numbers. Still plenty of work to do though, because again, these antifibrotic treatments stabilize and slow decline, but maybe not so much to improve. Wrapping up our case here, a couple minutes left. This patient was initiated on antifibrotic treatment with close lab monitoring, underwent serial pulmonary function testing, has been referred to pulmonary rehabilitation, palliative care, and lung transplant for evaluation. Continues to follow up with me in the pulmonary ILD clinic, as well as with rheumatology and his primary care physician. And in summary, we've talked a lot about diffuse parenchymal lung disease today and the approach to using a known versus unknown, inflammatory versus fibrotic features. Talking about our initial evaluation with pulmonary function testing, high resolution and non-contrast CT scans. The management is going to continue to evolve with some of our newly available treatments and studies, and that clinical correlation truly requires our multidisciplinary team of clinicians, radiologists, and pathologists, even from many different specialties as well. Thank you again for welcoming me to the University of Miami. Very happy to be here, and with that, I would welcome your questions.
Thank you, Dr. VEHAR. That was a very exciting presentation, and we all appreciate your polling technology. I think that's the first time I've seen it work so well and quickly. That was a really nice presentation, and I'm wondering what sort of I see Dr. Morris's picture on the screen, so immediately my mind is thinking, even before that, is infectious disease. And I'm wondering, what is the frequency of the use of antibiotics and other things when it's difficult to sort out exacerbations that may be related to infectious process versus just progression of the disease?
Right, and part of the answer is it really depends on what's going on with the patient. Certainly patients of mine who are often already on immunosuppressing agents, it's of utmost importance to look at both your routine infections and then also to rule out some of the opportunistic. It depends on what they are on And as far as once they do have a flare, I do a bronchoscopy with an infectious disease, BAL, the majority of the time if the patient's able to do so to really get that information, because otherwise you're looking at high dose of steroids in most of the cases. And once you have an acute exacerbation, the mortality is much higher. So most of the numbers we're looking at are in an outpatient setting, but certainly when they come in with flare, ruling out infection is incredibly important.
Great. Any other questions from the audience? That was great. I thank both our speakers. Oh, Dr. Punjabi, I see you unmuted yourself.
Yeah, hey, hi, Susie. Great, thanks for doing this. I agree with Dr. Weiss on great building a great team. Question, sort of related to ILD as a whole, where are we comparing, transbronchial cryobiopsy versus surgical biopsies in diagnostic yield? And where are we with genomic classification? Is that moving forwards? So my two-part question, how are we doing with transbronchial cryos? And how are we doing with genomic classification?
Yeah, so it's still a work in progress. So in that 2022 progressive pulmonary fibrosis guideline, they did not give a recommendation for or against the INVISIA genomic classifier that you're talking about. And as far as cryobiopsy goes, they allow it as a permissible, comparable study to surgical biopsy. What I can tell you is not all centers do that. Actually, when in training up at Cleveland Clinic in the main campus, they stopped doing cryobiopsy because of complications. So it is center specific. It requires that you have an experienced team, both on the procedural side as well as the interpretation side. The guideline doesn't give you a true sense either direction. I think it could go either way as the studies continue to come out, but the jury's out, a little bit controversial there.
Great, thanks so much.
Great. I thank both our speakers today for excellent presentations. Refer you all to the chat for the link to get your CME and MOC credits. And I look forward to seeing everybody next week. Have a wonderful and safe day. Go get them, guys.